Again, thank you so much for joining me for tonight's edition of Fertility 101. So this is going to be a basic overview of our practice, what we do at Illum Fertility, some things to know about how fertility works, testing that can be done, different options for treatment. And today is going to be a really broad overview of all of that, and hope you find it helpful. There will be a chance for questions at the end, so happy to answer any that come up as we go through the presentation. So I'm Dr. Laura Meyer. I'm a reproductive endocrinologist here at Illum Fertility. And as a fertility specialist, I help patients through all different methods of family building and fertility testing, and feel very lucky to have the job that I do and to be able to help people to build their families. And our practice, Illum Fertility, we are located in both Connecticut and New York. We have 5 different offices, and we are 9 physicians. We have an in-house surgical suite, an embryology laboratory, and we have a whole integrated fertility and wellness program. And I think one of the things that we're most proud of at our practice is that we really treat the whole patient, and we have a very integrative approach, and we really love what we do. One of the things that I want to talk about a little bit tonight in honor of Pride Month is the LGBTQ plus care that we provide here at Illum for families to be. We have a lot of resources here. We have the Gay Parents to Be website. We do fertility preservation for patients who may be transitioning. We have donor egg, we have an in-house program. We work with many donor sperm banks. We have a whole dedicated third-party reproduction team, and we have been recognized by the Human Rights Campaign Foundation as a healthcare equality leader for the last 7 years, and we are really proud of that. So what do we offer at our clinic? A whole host of fertility assessments and treatments. We do egg freezing, sperm freezing, embryo freezing. We do IUI and IVF, donor egg, donor sperm, surrogacy treatments. So a whole array of different treatment options depending on each individual case. And as I mentioned before, we have a really integrative approach, and we are also proud to offer referrals to counseling services. We have in-house acupuncture. We have 2 awesome dietitians who provide nutrition services, and we run lots of support groups. So we really try to help patients through the process in all ways possible. All right, so let's dive into it. So again, Fertility 101, this is going to be a very broad overview, but just to kind of understand some of the scope of what we do, and we will go from there. So the definition of infertility is either trying to conceive for 6 months or more without success for women who are over 35, 12 months or more for women who are under 35, or anybody who just might need medical intervention in order to become successfully pregnant. And that could be whether they have a partner or whether they're becoming a parent as an individual and need donor services. So there's a lot of different reasons why people could fall into this definition and could need some help in building their family. So there are 3 main things that we need in order to create a pregnancy. We need an egg, sperm, and the uterus. And we'll sort of walk through how we evaluate these different factors and how they play into the treatments that we offer as well. So a little bit about female anatomy. So here we have the uterus, the fallopian tubes, the ovaries, the cervix, and the vagina. And what happens is that when an egg is released from the ovary, it is typically swept up into one of the fallopian tubes. And if someone becomes spontaneously pregnant, in that case, sperm typically meets the egg inside of the fallopian tube to fertilize the egg and create an embryo. And that embryo can travel down into the uterus to implant and create a successful pregnancy. So this is a little bit about how the woman's menstrual cycle works and how that plays into what we just discussed. So each month, a woman has a group of baseline follicles, which are the fluid-filled sacs that contain the eggs. And she has sort of a new group of baseline follicles each month. And normally, in a regular hormonal cycle, her brain will make hormones that communicate with the ovaries. And out of the group of follicles that she has, one will grow to become the dominant follicle. And the egg inside of it will mature and will be released mid-cycle. So as that follicle is growing, it produces estrogen, which grows and thickens the lining of the uterus and prepares it for pregnancy. And then once the estrogen reaches a certain level, it triggers the brain to release a surge of luteinizing hormone, which is the body's cue to ovulate. After this LH surge, the follicle will release the egg, and the shell of that follicle sticks around. It becomes what's called the corpus luteum, and it secretes estrogen and progesterone. And these are the hormones that would support a developing pregnancy if somebody gets pregnant during that cycle. The corpus luteum has sort of limited function. So what happens is that if a pregnancy does not occur, that estrogen and progesterone start to wane over time. And it's that withdrawal of the progesterone that causes a woman to have a bleed and shed her lining, and then the whole cycle starts again. So one of the most important factors that you'll hear us talking about when we speak about fertility, and especially how things change for women over time, are changes in the quality and the quantity of the eggs. So when we're talking about quality, we're mostly talking about the genetics of the eggs. So the percentage of eggs that are chromosomally normal versus abnormal, and that changes over time. As a woman gets older, a higher percentage of her eggs are chromosomally abnormal. When we're talking about quantity, it's really the number of eggs that a woman has. And there's a few different ways that we can assess this. One is the AMH hormone, the anti-Mullerian hormone, which is a hormone that is made by the small baseline follicles in the ovary, those follicles that I was talking about before. So if a woman has more eggs and more follicles, her AMH is going to be higher. If she has fewer, it will be lower. There's also the day 3 FSH, or follicle stimulating hormone level, and that is a hormone that's made by the brain. It sort of communicates with the ovaries. And if a woman has fewer eggs in the ovaries, it's as though the brain has to work harder. It's all part of a feedback loop. So it starts making more FSH hormone. So that we like it to be below a certain threshold. And then we can also count the follicles in the ovaries on ultrasound at the beginning of the month. So there's a few different ways to look at these factors. When we're talking about this concept of the quantity, it's important to understand that while men make sperm on a continuous 3-month loop, basically their whole lives, for women, it's different. We're born with all the eggs that we'll ever have. The peak number that we have is actually when we're still in utero, even before we're born. And it's just a normal part of reproductive biology that over time, that number of eggs decreases when we're born and then hit the reproductive years. And beyond, it keeps declining. And then the point at which we hit menopause is when we're basically running out of eggs. So because of these factors and the changes that happen in the eggs over time, that is the primary driver of why age is correlated with a higher chance of infertility. And while fertility can be different at all ages, and there are some women who are younger who may need some extra help, there's also women who are older who may end up getting pregnant without assistance. We do know that on the whole, when we look at population studies, the probability of pregnancy declines as women get older, especially once we get to the mid to late 30s and beyond. And the sort of slope of that line, or the rate of change in fertility, becomes a lot steeper for women as we get older. So what are some other things that we can do to check someone's fertility? Well, in addition to the hormone testing that I just discussed, we want to check her anatomy. So one thing that we do is something called a hysterossalpingogram, or an HSG, which checks the fallopian tubes and makes sure that they're open. This involves putting a small catheter into the uterus during a speculum exam, and then putting some fluid through that catheter and taking X-ray pictures of the fluid filling up the cavity and hopefully spilling out of the fallopian tubes. This is an example picture right here. And you can see here, this is the uterus, the tubes, and the dye is coming out on both sides. So this person's fallopian tubes are open. Another test that we can do is a saline ultrasound. This also involves putting some fluid in the uterine cavity, but in this case, we take some 3D ultrasound pictures of the fluid filling the cavity, and this pushes the walls apart so that we're able to see inside the cavity well and make sure that there are no structural issues with it. So things like polyps, fibroids, scarring. We can also look for an abnormal shape of the uterus, things like that. In this case, this is the wall of an outside wall of the woman's uterus, and this is the inside cavity. The black part is the fluid that's going in. You can see that this patient has a large polyp. So that white spot that you see in the uterus is something that shouldn't be there, and that's something that could be handled surgically and through a minor procedure to take it out and help her chances of implantation, for example. We also look at sperm health, and this is another really important part of the equation. When we look at sperm, there are different factors that we evaluate. We look at the volume of the sample, the count or concentration, which is the number of sperm in millions per milliliter of sample. We look at the motility, which is the percentage that are normally swimming, and the morphology, which is the percentage that are normally shaped. And what we care about the most is what's called the total motile sperm count of the sample, which is basically how many swimming sperm are in the entire sample. What do we have to work with? And we can get that by multiplying together the volume times the concentration times the motility. So this is something that we look at and is a pretty straightforward way of evaluating male fertility. And when we find an abnormality, we may repeat the semen analysis to see if it's a persistent issue, and sometimes we may refer to a reproductive urologist who can do further workup. So they may then send hormone testing on a man, do an exam, make sure there's nothing else going on, and they can provide certain options as well for medical treatments and surgical treatments and things like that if an issue is found. It's also important to have health and lifestyle optimization. Certain things like smoking can also affect sperm health. And so these are all important things that we talk about and look at if we identify a problem. So there are many different causes of infertility, and some of them relate to some of the things we just talked about, or in terms of what we can evaluate. One is irregular ovulation. Sometimes women have a problem with their cycle in terms of ovulating on a regular basis, which can make it much more difficult to try to conceive and to know when to try and to be able to become pregnant. The most common reason for that is something called PCOS. Or polycystic ovary syndrome. There are other causes as well. So we always do a workup for that when irregular periods are found. As we talked about, one of the biggest factors in the decline in fertility is age. And so increasing age is a big cause of some of the infertility that we see. Sperm health. There are other things like endometriosis, which is when cells from the lining of the uterus migrate to other areas where they're normally not supposed to be. They could be in the pelvic cavity or in cysts on the ovaries. That can interfere with becoming pregnant. Tubal factor, so a blocked fallopian tube could be an issue as well. Uterine factor, like the polyp that we were just looking at. And sometimes it can be unexplained. We can do all the testing and it can be normal. And I always explain to patients when that happens, it can feel very frustrating sometimes not to have a concrete reason. But there's only certain parts of the process of conception that we're able to evaluate and check in a non-invasive way. So we can look at all these things we've talked about, the anatomy and the sperm and the hormones, but we aren't able to see a lot of the things that happen in the body, fertilization and embryo development and implantation and things like that. So sometimes there are other issues at play. And even if we have not identified a specific reason and someone is in the category of having unexplained infertility, we do have a lot of options for treatment and things that we can do to help people to successfully conceive. It's also important to note, again, that going back to that definition of infertility that we talked about before, people can also fall into that definition if they just may need some extra assistance to conceive. So people who are becoming a single mom by choice and using donor sperm, or a female couple that uses donor sperm, they can access fertility services as well. So these are other reasons that people come to us for treatment. So when it comes to fertility treatment options, there are a lot of different things that we do here, and really the specifics of determining what treatment is best for you is different in every case and depends on your situation. But we have things all the way from something a little bit more straightforward and less invasive, like ovulation induction. So when I was talking before about women who have PCOS, for example, who may not ovulate regularly, they may be able to take a medication to help them to ovulate on a regular basis and to be able to time intercourse so that they can have some opportunities to become pregnant. Other couples may do, or women may do an intrauterine insemination. So that can involve taking a sample of sperm and placing it directly into the uterus. That can oftentimes be done in conjunction with giving a medication. We also may do inseminations in the case of, for example, somebody using donor sperm. That sperm can be thawed and placed directly into the uterus at the appropriate time in a woman's cycle to help her to become pregnant. So there's many different reasons why we may do treatments such as that. We also do in vitro fertilization, and we'll talk about this more in a moment, but in vitro fertilization, or IVF, is a process in which the eggs are fertilized with sperm in vitro or in the laboratory instead of in vivo or in the body. And embryos are created and then can be transferred into the uterus at a later time. We do both sperm and egg freezing, different processes, but the idea being to be able to have sperm frozen for the future, or to go through an ovarian stimulation cycle and take out eggs and to freeze them. And these eggs and or sperm could be later thawed and used to create embryos and to create a pregnancy at some point down the line. We also have donor conception services. And again, this is something people may access for different reasons. There may be some women who are unable to conceive with their own eggs and may need to use donor eggs. And we work with some donor egg banks. We also have an in-house donor egg program, and we work with donor egg agencies as well. We have also a program to work with people using donor sperm. That donor sperm will come from a sperm bank, and it is sent here to our office and then used for either IUIs or IVF, depending on the situation. We also do surrogacy here, and that is when there's an additional person involved in the creation of the pregnancy that will carry the pregnancy, who is not biologically related to the pregnancy, so not the sperm or the egg source. And we'll talk about this more in a moment, but many different reasons that people may do this if they're unable to carry a pregnancy, or if we had a male couple or a single male, they may need to do surrogacy as well. So many different reasons that people come to these various treatments. So I'm going to talk through each of these very briefly, just to give an overview of what they entail and what each of them are. So egg freezing is a process in which a woman takes hormonal stimulation to stimulate the ovary, so that instead of her ovary maturing the one egg that it would in a typical month, like we talked about before when looking at the menstrual cycle diagram, she will take sort of a stronger version of the FSH hormone that her brain normally makes, but in larger doses, to try to get multiple eggs to mature at the same time and multiple follicles to grow. And then instead of ovulating those eggs into her body, we will do an egg retrieval procedure to take the eggs out of the ovaries. And then the ones that are mature that can then be frozen in the laboratory. The technology that we use for egg freezing is something called vitrification. It's a rapid or flash freezing protocol, which is very effective at safely freezing the eggs so that they have good survival rates at the time of thaw. The onset of vitrification, which is going back many years at this point, was one of the biggest developments within our field, and really allowed for egg freezing to become what it is today. And because of that, once vitrification became the dominant method in the field, the American Society of Reproductive Medicine lifted the experimental designation on egg freezing in 2012 when the technology improved and the success rates became much better. And that's why over the last decade plus, it's become so much more accessible and available. And these eggs, once they are taken out, can be frozen and stored pretty much indefinitely. They don't expire. And then they could be potentially thawed and fertilized with sperm and created into embryos in the future when someone is ready to create a pregnancy. Intrauterine insemination is a process in which sperm is taken and injected directly into the uterus. So sort of gets a little bit of a head start to where it needs to go, and then it will swim up into the fallopian tubes to try to meet with the egg. So in this case, a woman would be ovulating on her own. She may sometimes take medications to help her to ovulate or to release more than one egg. When the sperm is collected, it is processed to pick out the best swimmers, so to speak. And then it's put in this little skinny flexible catheter. We do a speculum exam and it's placed directly into the uterus. It's a very minor procedure, only takes a few minutes and it can be done in the office. And this is a less invasive, less expensive process than something like IVF. So this is something that we oftentimes may start with if somebody has unexplained infertility, if there's a mild sperm issue. For patients who need to use donor sperm, we may do an insemination. These are some of the reasons that we will pursue this. IVF is a more intensive process. So the start of the IVF cycle is similar to what I just described for the egg freezing cycle. So it's taking those same medications to stimulate the ovaries. They are injectable medications. They're subcutaneous, so small needle under the skin, and they're taken typically for about a week and a half to 2 weeks while a woman is monitored with blood draws and ultrasounds. And then those eggs are retrieved again from the ovaries. It's a minor surgical procedure under sedation anesthesia to do that. And once those eggs come out, instead of freezing them as eggs, like I described for the egg freezing process, those eggs can be fertilized directly with sperm to create embryos. And then the embryos that result are cultured in the laboratory until they reach the stage at which they can be transferred or frozen or genetically tested or some combo of those things, depending on the plan for that particular person. This is a more involved process. It does have a higher success rate, but it's more involved and invasive and expensive than the IUI. There are some scenarios where people will need to go straight to this. If there is a severe sperm problem, for example, some couples may do best with IVF, or if both fallopian tubes are blocked, IVF is the best bet. Sometimes people try the less invasive treatments first and may end up at IVF because they haven't had success with something like IUI. So it really just depends on the situation. Also worth mentioning that some of our female couples may do what's called reciprocal IVF, which is where one person undergoes the ovarian stimulation process, has their eggs retrieved, creates embryos, and then the other partner can have the embryo transfer and carry the pregnancy. So that is a great option for some people as well. Moving on to donor conception and surrogacy. So these all fall under the category of what we call third-party reproduction. And that's any situation in which an additional person is involved in the creation of a pregnancy. And again, this is something where people may use these services for different reasons. Some of our LGBTQ plus couples will be pursuing this. So female couples may use donor sperm. Single moms to be may use donor sperm. Men who wish to have a baby may be using donor eggs and a surrogate. So these are all options for those patients. And there may be other people who do not have sperm or can't get pregnant with their own eggs, who may pursue these as well. Some people also may need to use surrogacy if they either are not able to carry a pregnancy because they have had their uterus removed or have had complications during a prior pregnancy or have a serious medical condition that would make it unsafe to carry. So many different reasons that people may use one or a combo of some of these types of options. And we have a whole third-party reproduction department in our practice. And so we have a lot of experience in helping people through these processes. Also wanted to mention during Pride Month that we do have a program for fertility preservation for patients who may be transitioning. They may be taking medications or having surgical procedures that could affect future fertility. And so sperm can be frozen or eggs can be retrieved and frozen that could be used either now or in the future to help to create a pregnancy. So this is another service that we offer as well. So very broad overview of all of the different things that we do here in the practice. But for those of you who may not be a patient, we are always happy to meet with people and talk them through their options and help them with, their workup and figuring out what's going on and how to best help them to build their family. These are some QR codes for scheduling a consult. You can also go to our website that way. And we would be happy to help in any way that we can. And this is the list of our offices here too. So we do have a pretty broad geographical range throughout Westchester and Fairfield counties. And so that is sort of the conclusion of the presentation for tonight, but very happy to answer any questions that anyone has. There is a Q&A, like a function and chat. So please throw anything into the chat that you might want to know. And as I mentioned, happy to answer any questions. Nothing in there quite yet, but don't be shy. We're here to help and answer anything. So feel free to put anything in if you have it. Nope, I think someone raised their hand with a question. Okay, go ahead. Okay. Okay, so someone wanted to know, can you go over step by step the IUI process? Okay. So the IUI process, so oftentimes it may involve taking a medication prior to doing the actual IUI, although it will depend on the specific situation. Sometimes if someone just has a mild male factor, issue, then they may not need to take a medication, or if someone is using donor sperm who might be a single mom by choice or a female couple who doesn't have any known fertility problem, they may do the IUI by itself. But for those who have unexplained infertility or other issues, they oftentimes may be taking a medication like a Clomid or a letrozole. So these are oral medications that are taken for 5 days that can promote either ovulation in someone who doesn't ovulate regularly or may help someone to release more than one follicle. So instead of one, it might be anywhere between 1 to 3 or so. So that is typically taken at the beginning of the cycle. So a woman will come in when she gets her period. She'll have an early morning vaginal ultrasound and a blood draw. Then, if everything looks good to get started, she will take the oral medication for 5 days, and then she'll come in the following week for a vaginal ultrasound and a blood draw again to sort of see how she's responding to the medication, measure any follicles that might be growing, also to measure hormone levels to find out when is the right time to schedule the IUI. And once she's got one or more follicles that are the right size that we expect them to have mature eggs in it, she would take a medication to trigger ovulation. So that is a subcutaneous injection. It's a one-time shot. It's just a very small needle in the belly to program when she's going to ovulate, and then we schedule the insemination. And on the day of the insemination, if it was donor sperm, it would be thawed. If it's with a partner, they would produce a sample, and our andrologist processes it to get the best sperm. And then that sperm is drawn up into a skinny, flexible catheter. And in the office, we do a speculum exam, so almost similar to if you were having a pap smear. And then the sperm is placed directly through the cervix and into the uterus. It shouldn't be too painful other than the pressure from the speculum. The sperm is deposited in the uterus, and then we do a pregnancy test 2 weeks later. So that's sort of the overall IUI process. Hopefully that answers that question, but feel free to jump in if there's anything else. And then I have another question which says, not sure if you touched on this. What are your thoughts about women in their 40s wanting to get pregnant with the first child? I am 44 and giving myself another year to possibly get pregnant. What should I be doing? Okay, so very good question. So There are some things that people of any age should be doing when they're trying to get pregnant. So certainly like taking a prenatal vitamin, and what's good for your general health is good for your fertility too. So eating a well-balanced diet, taking good care of yourself, no smoking, no heavy drinking. So all of the things that that people of any age should be doing when they're trying to conceive, those things all apply. When it comes to age specifically, so, as I mentioned before, it's primarily the changes in the eggs and the ovaries that can make it more difficult for people to get pregnant as they get older. And it tends to be more that the getting pregnant gets difficult earlier than the being pregnant that gets difficult. So what that means is like women who are in their early to mid 40s, if they are in otherwise good health, many of them will do very well in pregnancy, and the uterus doesn't really age in quite the same way that the ovaries do, but it's really the ovaries and the eggs that can be the rate limiting factor. So if you look at just population studies looking at success rates of pregnancy at different ages, at about 30, the chances of conception are about 20% per month. And that's kind of the peak of natural fertility in terms of statistics. And that's why people try multiple months in a row. And most of those people will be pregnant within 6 to 12 months of trying. But by the time you get to 40, you're looking at about 5% per month. And by 45, it's about 1% per month. So it's not that it doesn't happen. There's women of all ages that conceive spontaneously, but the probability of it happening monthly goes down very, very significantly as you get older. And there's sort of more change that happens in the 40s. So I'll sometimes say to people, like the difference between being 42 and 44 is a lot bigger than the difference between being, 35 and 37, even though it's 2 years either way. There's just sort of more change that starts happening more significantly at that period in time. So certainly, again, it's hard to know who's going to conceive and who's not, but the chances of natural conception at that age are quite low. So I think what I would recommend is coming in and for an evaluation and to get checked out just on the earlier side. So it's not that I know it said here about giving myself another year. If you're 44 and you've already been trying, especially if it has been, more than 6 months, sometimes it can be helpful to at least get some testing to see if there's, anything else going on in addition. And we do have methods of treatment that can improve your success rates to some degree for getting pregnant, although it is true that fertility treatments as well in the mid 40s start to have much lower success rates. But we're always happy to do some testing for people and talk through options and, give advice that's more personalized to you. But so those are some things to keep in mind. Another question that came up is about estrogen or progesterone after IUI, whether it will affect future cycles. And then questions about getting to the root, and then as part of the same question about getting to the root cause of PCOS and diet and lifestyle modification. Okay. So we do actually not uncommonly supplement with estrogen and or progesterone after an IUI. What we typically will do is we'll have someone come in for a blood level on their first IUI a few days later to see what their body's endogenous estrogen and progesterone levels are in that setting. If they look excellent, we leave it be and we don't necessarily automatically supplement. But because it's something that is easy to take, doesn't have a lot of side effects, may be helpful in some situations, and because we're dealing with a patient population that's having a more difficult time, we have a low threshold for supplementing if the levels are lower. This just sort of builds on the hormones that your body is already making. And we have people come in for a pregnancy test 2 weeks after they have their IUI. So if they're not pregnant at that time, they stop the meds and they get a period. So we don't really see it affecting people's cycles so significantly after that. If you were staying on those long term, continuously, that could disrupt your cycle. But because we're sort of timing things specifically, we don't typically see it interfere. The question about strategies to get at the root cause of PCOS. So yes, we actually have a whole PCOS program, and it is an integrative program. So we check hormone levels. We also check for some of the medical things that come along with PCOS. So women with PCOS more commonly can have some signs of metabolic dysfunction. They may have abnormal blood sugar tolerance. Sometimes they're genetically predisposed to this. They can have higher cholesterol. There's things like that that can go along with it. So we check all of that. To try to help with some of those things and to screen for them, to check hormone levels. Our dietitians are very helpful too in helping people to advise people about nutrition from a PCOS perspective specifically. Some women, although not all with PCOS, may have more difficulty maintaining a healthy weight. That can be one of the predispositions that goes along with it as well. And so the dietitians can be helpful in helping people to understand some specific considerations related to PCOS and how they eat and how to manage that to try to optimize health from that perspective. So it is PCOS is in some ways a genetic predisposition. So it's not something that can be cured or gotten rid of per se, like that underlying predisposition will always be there. But sometimes through various lifestyle modifications and health modifications and sometimes medical treatments, we are able to help people to manage the symptoms and, and to do well with it. And we do see that, for many people, that can help them to, successfully become pregnant or to help to get their periods back or manage some of the symptoms that come along with it. Let's see. I see here another question. How do you go about finding your ovarian reserve? So the best way to do this is, as I mentioned, the combo of the ultrasound to check the antral follicle count, and then also the blood test. So that day 3 FSH and the anti-Mullerian hormone. It says here, would I have to make a consultation? So yes, the way that we can best help you to do this and to be able to schedule the ultrasound and do all of that would be to see you for consult. So we see people in all of our offices, our 5 offices throughout Westchester and Fairfield. But we also see people virtually too. So Zooms, just like this, I do lots of them every day with patients. So we can try to make it really convenient for you. You could speak with one of our new patient liaisons and they would set you up with an appointment with one of our physicians. We could get your history and walk you through testing options and then bring you in for a vaginal ultrasound and a blood draw to get the testing and then, to counsel you about those results and what they mean. Any other questions? All right. Well, thank you all very much for joining this evening. Really appreciate you taking the time to be here. We're happy to help in any way that we can for anybody who would like more information. So please feel free to reach out. And I hope you all have a wonderful evening. Take care.